Today I'm going to be talking about infant pyloric stenosis. What is pyloric stenosis? Pyloric stenosis is a form of gastric outlet obstruction. It's an obstruction of the pyloric lumen due to pyloric muscular hypertrophy. It is most commonly found in infants between 4 and 8 weeks old. It is a medical emergency and it is the most common reason for surgery in the first 6 months of life. Here is a picture of pyloric stenosis where you can see the hypertrophied pyloric muscle. What is the epidemiology of pyloric stenosis? It occurs in about 200 out of 100,000 births. It accounts for 30% of all patients with non-bilious vomiting before 1 year of age. It usually occurs in full-term infants and is rarely found in preterm infants. Males are affected 5 times more than females. It is most common in Caucasians, and a genetic component does exist. An infant with pyloric stenosis will present how? Over time, the vomiting progresses from infrequent to nearly after every feeding and becomes projectile. The infant is always extremely hungry and nurses avidly, but in later stages, the infant may lose interest in feeding and may lose weight. Dehydration is very common. The infant will have a loss of skin turgor. An olive-sized tumor may also be felt to the right of the umbilicus, and the upper abdomen is distended and gastric peristaltic waves can be seen. The infant will also present with lethargy and infrequent bowel movements. The patient usually does not look ill or febrile, however, it is very important to diagnose early. Questions to ask if you suspect pyloric stenosis. For how long has your baby been vomiting? Usually vomiting occurs shortly after birth. Does your infant vomit after feeding? Parents may describe vomiting with every feeding. Is it getting worse over time? Vomiting worsens with time and becomes more forceful and projectile. What does the vomit look like? Bilious vomiting is not common with pyloric stenosis. Is your infant losing weight? Infants are usually dehydrated and may be malnourished. Has there been any associated diarrhea? You want to ask this question to make sure to eliminate other GI problems. And lastly, is your infant feverish? Fever is not common with pyloric stenosis. If an infant has a fever, it should alert you to other possible etiologies of vomiting. What do you do if you suspect an infant has pyloric stenosis? You want to make sure you obtain a detailed history and physical exam, and diagnosis can be made by palpation of an olive-like mass. Typically, this mass is 2 to 3 centimeters, firm, movable, and is on the right side of the epigastrium. Ultrasonography is important in the diagnosis of pyloric stenosis. Diagnosis is made by identifying the hypertrophied pyloric muscle by abdominal ultrasound. The sensitivity and specificity are almost 100% for the diagnosis of pyloric stenosis. If the diagnosis is uncertain after ultrasound, a barium swallow will show delayed gastric emptying and the typical string sign of a markedly narrowed, elongated pyloric lumen. You want to make sure to obtain a complete metabolic panel due to the dehydration status and severe potassium depletion. And you also want to make sure you have an early diagnosis. Establishing an early diagnosis in the newborn or young infant with vomiting can sometimes be difficult. On the other hand, delayed diagnosis may lead to malnutrition, dehydration, aspiration pneumonia, and other severe complications. Here is an ultrasound of a 6-week-old female who presented with projectile vomiting. This ultrasound shows the thickening of the pyloric muscle. What is the treatment for pyloric stenosis? Pre-operative management includes rehydration and correcting the electrolyte imbalance. Most infants can have their fluid status corrected within 24 hours. Severely dehydrated children, however, sometimes require several days for correction. Adequate amounts of both chloride and potassium are necessary to correct metabolic alkalosis. The treatment of choice is the Ramstead longitudinal pyloromyotomy. This is accomplished by cutting the pyloric channel and cutting the muscle of the pyloric channel, which widens it, and then which induces regression of the muscle hypertrophy. You want to make sure to never prescribe erythromycin and never fail to recognize dehydration or failure to gain weight. Postoperatively, the infant usually tolerates feeding within a few hours. Follow-up care for pyloric stenosis. Feeding can be resumed over a 24-hour period. Infants can be discharged once they remain hydrated. A post-op visit 1 to 2 weeks after surgery to document weight gain. You want to make sure to educate the parents that reoccurrence is very rare but may occur, and the infant should have normal function within months of surgery.